congenital cataract, etiology and morphology, symptomatology, and management. Well, so can anybody tell me how you define a cataract? Only one rule. How you get it?
It's in the lens or exception.
Yes, very good. So only because it's a very good definition. That is, it is opacity within the lens, or it is capsule. Because lens has two parts. Lens has two parts. One is the capsule, other is the lens. The lens is placed in the capsule. Lens is placed in the capsule. So that is the difference. That's the difference in a camera and an eye. That's the difference. Because the camera uses movement. It goes front, it goes back. It goes front and it goes back to have focus for the near as well as for the distance. Eye has a different this. Eye has the curvature change. It is a curvature change. Anterior curvature or posterior curvature. More on the anterior curvature. So which has fixed from here, it will change its curvature. That's why after 40 years you need not any glasses for the near. Once you have to see the distance, the anterior capsule flattens. The anterior capsule flattens. So in order to show the distance. So as you rightly said, very good definition, that any opacity in the lens or in its capsule is called cataract. So same definition applies to the congenital cataract also. Cataract is cataract, whether it is in babies or it is in adults. So next we go, there is one demarcation, that is a congenital cataract and then developmental cataract. Yeah. Congenital cataract and developmental cataract. If somebody asks you, what is the difference between a congenital cataract and a developmental cataract? Remember this thing. Congenital cataract is baby is born, there is cataract. This is congenital. Okay? Baby is born, there is no cataract. It develops after 1 or 2 years. That's development. Okay? There is already a problem. There is already an intrauterine insert. But that is not manifested at birth. That is not manifested at birth. That manifests at 2 years. Manifests at 3 years. And that's called a developmental cataract. So remember again, anybody asks you, congenital, developmental, because frequently asked question in the Bibles, and this one difference between congenital and developmental. We just tell that congenital is present at birth and developmental appears later. Finish. No second question, no second thoughts. Okay? Now we go to the classification. Classification, I mean, I have made it clear what's cataract. Now we go first to the etiology. Etiology means what's the cause? What's the cause of congenital cataract?
Senile cataract.
We are not talking here of senile cataract. We are talking of congenital cataract. Because senile cataract, just silence. Senile cataract we know. It is going to happen after 50, 60, 70, 80, what? It's an age related. There is an age related oxidative stress or age related UV damage or other oxidative stress that leads to ultimately to the cataract formation. What's cataract formation? Technically, it is a classification of transparent fibers. Normally, the lens fibers are transparent, but they become opaque. That's it. So once we apply it to the adults. How we can apply it to the congenitals? Why should the cataract develop at birth? There will be many causes. I will just organize them. First thing, It is genetic. First thing,
Genetic.
remember this is genetic. That means autosomal dominant and autosomal recessive type of pattern. Okay, this is one class. This is one class. Second is idiopathic. That may also be genetically related. So majority of the congenital cataracts are genetic. They are genetic. Then there is some class of congenital cataracts which have what they have? They have infective cause. They have an infective cause generally we organize into torch. Torch is a group of this sort of infections because these stands for tuberculosis. O for others. There are various infections in that. R is for the rubella. C is for cytomegalovirus. And H is for herpes simplex. So this is the infective cause of cataract. This is the infective cause of the cataract. And others you have varicella zoster, which is a variant of herpes zoster. Which is a variant of herpes zoster. Or you have many other syphilis like that, other infections, which are, I think, because syphilis is a venereally occurring infection in the baby. Okay? Because if the mother is syphilitic, it can transmit to the baby. So this was the torch group of infective cause of congenital cataract. Then we have one more class of problems, that's metabolic. That is metabolic and predominant among them. Predominant among them is the galactosemia. This is galactosemia. And the other causes of hypoglycemia. Hypoglycemia. Okay? Because if the mother is diabetic and baby can develop hypoglycemia. Okay. Then other causes of hypercalcemia. The calcium level goes up. Okay. So galactosemia, hypoglycemia, hypercalcemia. So these are some of the metabolic causes. Then there are other causes. That's in which eye has an abnormality. Eye has a, or there are systemic syndromes. There are systemic syndromes. Most common syndrome I feel in children is the Down syndrome. You must have read in pediatrics. That's a Down syndrome. Okay, that can, and there are many those syndromes. Marfan syndrome, then other syndromes, many syndromes which can be associated with the congenital cataract. There is one more within the eye. If there is some problem within the eye, there is some problem. One condition is called PHPV. That's called PHPV. That's persistent hyperplastic primary vitreous. Persistent hyperplastic primary vitreous. So, in which there is some primary vitreous in the vitreous, that is not because vitreous is replaced by secondary. Primary vitreous is replaced by secondary vitreous. Because primary vitreous has a blood supply. It has a blood supply. And it can lead to, because those hyaloid vessel goes from the posterior core, it comes to the lens anterior. If that persistently remains with the primary vitreous, that can cause a posterior lenticular pest. That can cause posterior lenticular opacity. Other causes, have you heard of retinopathy of prematurity? ROP. ROP is a disease. ROP is a disease in which the child is born prematurely and his or her birth weight is very less than 1500 grams or 1.5 kg. Then the child remains in the ICU under high oxygen setup for prolonged periods. So they develop a disease called retinopathy of prematurity. And that disease leads to neovascularization, new vessels in the retina, which can even ultimately cause tractional retinal detachment if not treated properly. So cataract is also associated with that disease. There is one more condition that is called lenticules. That's called lens conus. Posterior lens capsule, it is a conus. It has a conical edge. Even that can lead to lenticular opacity. Lenticular opacity. And one of the causes, if you have some other syndromes like aniridia, absence of the eyes, in such babies are also prone to cataract. So, some of the classification I have given you. So, you can remember like this. This is one of the classifications. Not classification, this is the number of patients of congenital cataract which have come to a hospital and then they have given a percentage. Okay? Suppose autosomal dominant, autosomal recessive. Okay? Around 20 patients they have. And idiopathic, they had around 27 patients. Okay? Almost 50% are unknown causes. They don't have a cause. Then there are the cause I have told you. Okay, this is predominant again, around 37% or 33%. Then metabolic causes I have also told you. Then trauma, that's also. Then developmental, I told you posterior lenticulus or persistent primary hyperglycemia or anterior segment dysgenesis. Anterior segment dysgenesis means the anterior segment is not developed properly. Okay. The cornea will be small, the eyes will be having many problems. And then others I told you, retinopathy, these are some of the syndromes. But most important syndrome I think is the Down syndrome. Okay? Then other things are like Peri-Robin syndrome, Coats disease, Lowe syndrome, Warburg-Mycroft syndrome, Raynaud syndrome, muscular dystrophy. These are the other causes of congenital cataract. So we can go back. I have given some idea about the etiology. Now next we go to the classification. Next we go to the classification. So there is one group of congenital cataracts. They have some opacities. They have some opacities, small opacities in the periphery of the lens. That's called blue dot. One more, suppose the anterior capsule. If there is opacity at the anterior nodal point, okay, that will cause vision problems. That's called anterior. That's called anterior capsular cataract. Anterior capsular cataract. Same way, if you have cataract at the posterior at the nodal point, at the center, that's called posterior capsular cataract. Okay? Then one more we have, that's called is a nucleus. The nucleus. That will be called as nuclear cataract. That will be called as nuclear. So we have blue dot cataract, we have anterior capsular, we have posterior capsular, we have nuclear. One more is that's called zonular cataract. That's called zonular cataract. Zonular cataract is typically, suppose this is the lens. One, it has multiple fiber layers. Suppose just 100 fiber layers. 50 on this side and 50 on this side. In between some fibers, they become opaque. But it manifests later. It's a developmental type of cataract. It's a development. Because there is some anoxia. There is some anoxia during the development of the lens. The blood supply or oxygen supply to those fibers have been affected. And it manifests later in the life. It's not present at all. So what happens? There is opacity. Outside that, there is a clear lens. Inside that, there is a clear lens. And classically, they have some riders in the periphery. They have some riders in the periphery. One more is that's called membrane cataract. That's called membrane cataract. Membrane cataract means that the cortex within the lens is absorbed. Cortex is absorbed. Now it means the anterior capsule and posterior capsule. They get fused. Get it? Fused. This is called membrane state. This is called membrane state. And then one more we have, that's called sutural cataract. Because lens fibers have sutures. You must have that. You must have that. They have Y type of sutures. They have Y. So you can have anterior sutural cataract or posterior sutural cataract. Okay, that is the shape of Y. Again, the sutural cataract does not have much visual problems. So it remains as an asymptomatic thing. But if it causes visual problem, then it needs to be caused. So two cataracts, they don't cause much visual deterioration. One is sutural and other is below. Remember? So others they cause. One more cataract is natural cataract. Is it? Natural cataract. In which the whole lens is opaque. It can be unilateral or it can be bilateral. It can be unilateral or bilateral. So again I repeat, below dot, anterior capsular, posterior capsular, nuclear, zonular, nuclear, zonular, then membranes, sutural and natural. These are 6 or 7 types of congenital cataract. You repeat.
First we have capsular cataracts, in which we have the anterior capsular.
You tell me the names, you don't explain.
So blue dot cataract, congenital capsular cataract, congenital nuclear.
Congenital capsular are 2 types. Anterior as well as posterior.
And congenital nuclear cataract.
Good.
Sutural cataract. Zonular cataract.
Zonular cataract. That's called also lamellar. That's called lamellar. And mature cataract. So this is the problem that 6 out of 10,000 children are affected with this. So it has multiple importances. Then 10% of the childhood blindness. Why is blindness? It's a cataract, it can be operated and it can be, vision can be restored. Why is blindness? You know? Because just suppose a mature cataract, unilateral mature cataract. Child is not seeing. His macula will not develop. Okay? So he will develop amblyopia. He will develop amblyopia. That becomes irreversible. That becomes irreversible. So before the macula develops, or you intervene early in a unilateral mature cataract, you can reverse it. What is the sign at which it becomes irreversible? Nystagmus. Surging nystagmus. Surging nystagmus. So the patient does not have vision. Once the child develops nystagmus, even if you now operate, prognosis is not good. Okay? Okay. So this was unilateral mature cataract. So we assess. Suppose now baby is born with a cataract. How they present? What will be the symptoms? The mother may tell silence. Mother may tell the child is not recognizing people or recognizing objects. Okay? Or the parent will not opacity. Why opacity in the pupillary area? Okay? Or child will develop nystagmus. Or child will develop amblyopia. So these are some of the manifestations of the congenital cataract. How they present? Because it's a very the problem is of emergent nature. Suppose you have unilateral macular cataract. Now, if you don't operate in time, child will have a wrong standing or lifelong blindness. It's a very serious thing. It's a very serious thing. The child lands in blindness at the moment. So, if you have some eyes, cataract in both eyes, it is less likely to cause amblyopia. It is less likely to cause amblyopia. But if you have in one eye only, then it is more likely to cause amblyopia. One more thing is that if whether the cataract is mature or it is a sort of immature type or partial. Okay, because in partial the child will see something, if not whole thing, and the likelihood of amblyopia is less. Likelihood of amblyopia is less. Suppose now there is a mature cataract, and 1 month, 2 months, 3 months, if you have not operated, it will go into the stagnant and permanent amblyopia. You understand? So that's a very serious thing. So if child has a natural cataract and then child has a natural cataract and it's our responsibility as clinicians to tell the mother, to tell the parents to get the child operated for this. Otherwise, child will land up in permanent blindness. These are the points I have already explained to you, whether it is present in one eye or it is present in 2 eyes. Whether it is visually significant or not. Like below dot cataract, I told you, is not visually significant. Suicidal cataract, it is not visually significant. Then, whether it improves, it increases return or decreases return. Okay. Generally, it will remain stable or it will increase. So if it will increase, then we have to operate. Partial or complete, I have told you already. Because it's a mature complete, that means it has to be operated. So if it is very tiny or small, or there is partial opacity in the lens, it can be, you can wait. These things you must be knowing, the components of the lens and this. These I told you already. Concrete. Suppose these are what I was telling you blue dot. These are some opacity lenses in the gravity of the lens. This is called blue dot. This is sort of a zonular layer. This is sort of a zonular layer, in which some fibers get opacified. Some fibers get opacified. Silence. Some fibers get opacified, and fibers inside that opacified is clear. Fibers out that opacified area is clear. So it's only those particular group of fibers. And the classical about this is they have these are called riders. These are riders. They go to the equator. A group of fibers from anterior to the posterior. Because fibers are formed from the anterior to the posterior. In a particular plane with riders, you label it as laminar or zonular. The nuclear cataract, you know, it is the very center of the nucleus. So this is the lens, and the center part of the nucleus is opacified. This will be called as nuclear cataract. Anterior capsule, I know we talked about, it is present in the anterior capsule. But suppose this is the lens, this is present here. Okay? At the anterior lens capsule, like this. So this is the lens capsule, this is present here. And it will cause more vision problem because it comes with the optical axis. Anterior capsule, posterior capsule same. Suppose this is the lens and there is this, and at posterior capsule, because it's the cornea, at posterior capsule you have opacity which is again in the visual axis. So patient in child will have problems in the vision. Suture, I told you, this is a Y shape along the sutures of the lens fibers. Membranes also, I have told you, the cortex is absorbed, anterior and posterior capsule fuse, and it becomes a membrane state. So now we are diagnosed with the cataract. Now we want to operate. What will we do? First we will inform the parents. Because these children, they have some problems in the retina, sometimes in the vitreous. Then the prognosis becomes guarded or dim. So what we do generally, we put them on atropine ointment for 3 days. And then we do an evaluation under anesthesia. EUA, what's called? EUA. Because we want to see whether vitreous is okay, whether retina is okay, whether there are any other problems in the eye which will affect the prognosis. So we have to document. Okay? That has to be done under general anesthesia. Next we will go to the surgical part. Now we want to operate on the scalp. What is the problem here? Because we have placed intraocular lens. We have to place it. So the problem with them is biometry. Biometry is what? It's a calculation of intraocular force. It's a calculation of intraocular lens force. So, because the child will not keep the eye, we cannot measure the axial length, or we cannot measure the keratometry. You understand? So, that is the problem. But we depend more on the axial length. We depend more on the axial length. We sedate the child, or we take under anesthesia, we can measure the axial length, or we can do a keratometry also in some cases. So, once we have done the keratometry part, or the axial length, or the biometry part, we have reached to some lens form. We have reached to these eyes are isometropic, they are small eyes. With age they enlarged. Okay? So in them we do under correction of the calculated form. Suppose it is 30 diopters. Suppose it comes 30 diopters. So if child is less than 1 year, if the child is less than, we will deduct 40%. How much? 40%. If child is less than 2 years, we will deduct 20%. We will deduct 20%. If child is above 2 years, 2 to 8 years, we will deduct 10%. We will deduct 10%. So once we have now reached that we will put this much of hope. Suppose child is 2 years. I have a biometrical evaluation and biometrical calculation. It's showing 30 diopters, suppose. I will deduct 20%. That's around 6 diopters. That is, instead of 30, I will put 24. Okay? So less than 1 year, 40%. Less than 2 years, 20%. And 2 to 8 years, 10%. Remember this. So, that I told you, diminution of vision, or he does not recognize objects. Or one more thing is deviation. What's called strabismus. squinting. Because once the eye will land in amblyopia, it will squint. It will squint. It will go out. You do one thing. You just go through your cameras, open up your mobiles. Take a picture of this. You will remember the causes. Taken? Okay, now I will go ahead. Take a picture of this. Types of cataract, morphological types of cataract. This picture, lower picture. You can see here, child has a natural cataract in both eyes. Okay, so he will not be seeing anything. Silence. Why you are talking here? What's your problem? So these are the things you may have to do. This is a detailed history because there is a syndromic genetic element in this. Then you can have complete ocular examination, uncorrected visual acuity, miscorrected visual acuity, pupillation, V-scan. V-scan do when we do V-scan. V-scan is an ultrasound. It's a when we do. Once we can't see the retina. That means suppose patient is a mature cataract both eyes, or you are not able to see the retina vitreous. So we will do a V-scan. A-scan, I told you have to measure axial length or ion orbital position. Then retroscopy is this, I can do in photographs you can use. Okay, now we go to the surgical part. So there are some difficulties in children. They are not like adult eyes. What are difficulties? Because this sclera is soft. That's called low signal region. What's called? It's called low signal region. Because every incision we make in adults, that sees. But in children it cannot see. So ideally, once we are doing a cataract surgery, in children every incision has to be sutured. Okay? Otherwise, once if you don't suture in the post-op, it can leak and chamber can become flat and there may be other problems. So they have low signal rigidity, their incisions are leaking, so we have to suture every incision. And one more other problem in them is that once we make capsular access, you must have seen many of you, once we cut the anterior capsule, then it becomes an opening through which we remove the cataract. But in them there is a problem in capsular access. What is the problem? The capsule is very elastic. It's very difficult to control. And make a capsule access. So generally the recommendation in them is that we put a dye in the anterior chamber. Normally we put in adults also, we just stain. But in them it makes the capsule harder or thicker, so the access becomes easy. Okay? And you must have seen that we are doing the capsular access with the needle. We are doing with the needle. That needle is called sister tube. That's called sister tube. But in them, the recommendation is we should use the forceps. We should use forceps because the control is very good with the forceps. Because if you do with the needle, it can go running. And once you do with the forceps, your control is better. So you can make it relax. This is the third point. First I told you, they have low circulation. Number second, I told you, incision has. Number third thing I have told you that the capsule is very elastic. So we have to put pliable below, we have to use forceps to make a capsular relaxation. Then removing the cataract is not a problem. It's very soft. You can do with irrigation, aspiration and remove it. Okay? But in them, if the child is less than 5 years, in them, if the child is less than 5 years, we do a procedure that's called posterior capsulotomy. That's called posterior capsulotomy. The way we are doing the capsule access in the anterior capsule, we are doing the capsule access in the posterior capsules. So anterior capsule we are doing 5, posterior capsule we have to do 4, less than that, or 3.5. Why we are doing posterior capsule access? Anybody? So विचार क्या होगा अपने साथ? चलो कांति You come with me. Silence. So the anterior, basically, the adults also there is posterior capsular opacification. There is a posterior capsule. This is a late complication of cataract surgery. After 6 months down the line, the patient will complain of I cannot see distance clearly. And once you do a center examination, you see behind the lens there is opacity in the posterior capsule. But in children it's very high because the epithelial cells are metabolically active. And epithelial cells are where? In the anterior capsule, not on the posterior capsule. They migrate from this. It is calculated in 100% of congenital cataracts develop PCO. Develop PCO. So that's why posterior capsule, this posterior capsulotomy is done. Not only posterior capsulotomy, we do also anterior vitrectomy. Anterior vitrectomy. We do an anterior part of the vitreous. Okay, because not only the posterior capsule, the anterior vitreous can be a scaffold for posterior capsular opacification. You understand? So we have to remove the posterior capsule, part of posterior capsule, and we have to remove the anterior part of the vitreous. Anterior part of the vitreous, but it's called anterior vitrectomy. So once we have removed, we have made anterior capsulotomy, we have made posterior capsulotomy, then we put the lens in between these two. Okay? There is anterior capsulotomy which covers the lens, there is posterior capsulotomy which covers the lens. This one surgeon, he has done a very good idea. What he has done, because this IOL has 3 parts, it is optic and haptic. He has taken this he has taken this optic behind this posterior capsule towards the vitreous. That's called posterior optic capture. That's called posterior optic capture. Because once you take a 5 mm or 6 mm optic to a 4 mm capsule, so that 4 mm capsule will hold it. What is the advantage? The advantage is the stability of the IOL is very, very high in the long run. Okay? And number 2, such people have been shown to have very, very less PCO. Okay? One is stability of the IOL and other is the PCO rates drop significantly. PCO rates drop significantly. So, there is one more idea because once you are putting an IOL, you are undercorrected. With age, the eyeball enlarges and you may develop myopia. Some people have put one type of lens in the eye which can be secured Which can be, and their power can change. Their power can change. This is one more idea. Suppose I have put 22 diameters. Now at the age of 20 years, patient needs 24. Patient needs 24. Or patient needs 20. Suppose patient needs 20. I have put 22. Patient needs 20 in my opinion because he has -2 for the distance. Okay? Then you can, if you have put that secure type of iron, you can go and you can do it clockwise or anti-clockwise, you can decrease this power. You can decrease this power. So 22 can become 20 and patient will regain vision. So these are some sort of secure type of irons. So these were some points which are different in the adult, from the adult cataract surgery in children. Then if we see the long-term outcome, what are the problems they face? What are the problems they can have? One I told you, myopic shift. Because the eyeball is enlarged. Eyeball is enlarged. Then other things, now we have done a posterior capsulotomy, we have done an anterior vitrectomy. So that becomes a risk factor for retinal detachment. That becomes a risk factor for retinal detachment. That's very small risk, but these children ought to be put on the follow-up lifelong. These children ought to be put on the follow-up lifelong for this complication. That is the retinal detachment. One more complication they can develop is glaucoma. They develop glaucoma. So you have to follow them every 6 months or yearly. One is for refractive status. One is for refractive status, myopic shift. Number second is retinal detachment, and number third is glaucoma. And one fourth problem they can have, the eye gets decentered. The eye can get decentered. If it gets decentered anteriorly, posteriorly, laterally, then we have to intervene. One more problem they can have is that I told you PCO. PCO is very common. PCO is very common because their anterior epithelial cells are very active. So what you will do in that? So you will do a laser. You will destroy that PCO with the laser. So open up your camera. Open up your camera. Suppose we measure the axial length only. If we measure the axial length, it comes 17 mm. We will put 25 diopters. If it comes 18 mm, we will put 24 diopters. Less the axial length, more is the power. More the axial length, less is the power. So at 17, we will put 25. At 21, we will put 90. Okay? So lesser the axial length, more is the power. 17 is 25, 18 is 24, 19 is 23, 20 is 21, 21 is 90. Remember this formula. This can be done without calculating.